Ladies and gentlemen, friends and colleagues, we're coming to the end of what certainly for me, and I think for many of you, has been an extraordinary 4 days. You will no doubt have all your own impressions and memories. For me, there have been many inspiring conversations, laughter, lots of laughter, tears for me when Atul Gawande spoke, and I'm certainly struggling not to disgrace us all by crying when I was chairing the session from Japan and today from Afghanistan. But you will have your own impressions, memories to take back. We thought it would be useful as a reminder of the last 4 days if we showed you a brief video. That's what follows.
Well, this is the second forum I've been to. I came 2 years ago to Berlin, and I felt that the insights I gained then, were so valuable that I wanted to come back 2 years later and actually see how the forum's evolved, but also perhaps this time looking much more at sustainability. Probably what I'm noticing at this particular forum is that most of the health systems across the world are continuing to grapple with the same problems, and the ability to network and to learn from each other was an opportunity too good to miss.
I'm really interested in global health and particularly healthcare in developing countries and resource-poor settings, and I feel that quality improvement is the basis for building sustainable structures there, as well as structures which support the most important needs of populations where resources are very limited.
So our meeting here these days is about better healthcare, improving the health of populations, and doing all that in as controlled a budget as we possibly can. Big challenges, I know, but together you're going to meet new people, you're going to have great experiences here, and I think really return to your home organizations, your home countries, with a renewed will to change and with the great ideas that you need.
It's been amazing, the amount of information. It's only day 2, but we've learned a lot.
It is great. We're learning a lot from the international experiences, and it's answering a lot of our core and shared problems domestically and internationally. It's a great experience to be here.
I've certainly seen that over time that more and more senior people are coming here, which again I think is around all of us valuing that safety is probably the most important thing that we do. Everybody's friendly, everybody wants to learn from each other, and I'm probably finding that our stories now are all adding value. It's not just about perhaps one system being a leader in all fields. I think we can all learn from each other, so that's been fantastic.
I'm looking so much forward to meet friends and colleagues to discuss the issues that we are working with every day, get news ideas, go home and do something about it.
The atmosphere is quite exciting, I think, really. I mean, there's so many stands with lots of different organisations here, lots of things to pick up and find out about. Generally, just really interested and excited to find out what's in store in the next few days.
It's great to get together with a bunch of like-minded people who share that, and the energy builds up.
Inspiring, friendly, energetic, fantastic.
Big, vibrant and exciting.
Thank you very much.
So we hope we'll see a lot of you in Paris, and we hope you'll encourage your colleagues and other people who may not think to come to Paris. And particularly we want to hear from you about what we should be covering in Paris. So when we ask for your feedback, it's not just a bureaucratic tick box thing. We're really, really interested to hear what you want the forum in Paris to be like. You'll be asked by email to deliver some feedback, and if you have additional comments you want to make immediately now or over the forthcoming year, please send them to events@bmjgroup.com. We really, really want to hear from you. The other thing, just to remind you, is that as delegates who've attended this meeting, you have on the website, internationalforum.bmj.com, many of the presentations. We hope all of the presentations will be available over the next few weeks, and the videos of 35 of certainly the plenary sessions and some of the other sessions. Those are all available to you as attending delegates of the meeting. And finally, if you wanted, before we move on to our main event, our closing plenary, if you want to extend the influence of this meeting within your organisation, we hope that you will take the opportunity of encouraging your organisation to take up a remote participation package. We have had 2,000 people via their organisations, 2,000 people in 10 countries who will be joining and benefiting from this meeting through the remote participation package. So if you go to the website or if you email events@bmjgroup.com, you can find information about that, and you yourselves could become a hub within your organisation to extend this opportunity to other people. So please do take that up. Finally, before I hand over to Joran Hendricks, I just wanted to thank again our local hosts, the Dutch Healthcare Inspectorate, the Netherlands Organisation for Health Research and Development, for their wonderful hospitality. Thank you very much. And now over to Joran Hendricks, Chairman of our Strategic Advisory Board.
Thank you, Fiona. You are fantastic. Just as fantastic as you all are, you are a wonderful community. And let's keep us as the community that gives hope to everybody that works in this fantastic business, healthcare. And we are privileged that have had the chance to come together here in the Netherlands together and get this fantastic conference. So even if we applaud once, Fiona, for the Netherlands, let's do it once more. Thank you very much. But it's not only the Netherlands. I try to find words connected to the two organizations. And if I should describe IHI, I would like to describe them as the most inspirational, healthiest improvers in the world. Let's give IHI an applause. And then, what can you say about BMJ? Well, BMJ, they makes me bold, as in B. They give me more network possibilities, opportunities than anyone else. And finally, they have told me how to join a movement of change of healthcare. Let's give them also a big applause. When I have the chance, what have I learned? Well, I think that Maureen's start with all teach, all learn was fantastic. I love Gilbert already. Gilbert is my hero, and I will bring that home. I heard about the new level of safety, the generative safety work that the Shell CEO told us about. I heard about resilience. I heard about hope from Cambodia and Afghanistan, and felt a little guilty that can they do all these things? Why cannot we always do it? I also heard about this fantastic work that all the different systems are doing around improve the students, improve the professionals. And when you mix all that together, we can't come home and say, well, it was as usual. We have taken a fantastic step because now we have summarized everything we know, and now we have to do what Jim Easton challenged us to do, to improve the improvement. So the next step for Paris, London, Paris, has to be, how can we do this even better? I think everything starts with what we imagine. John Lennon wrote a beautiful song. But what we now will end this forum with is a challenge in imagination. Are we ready to change our work processes? Are we ready to prepare for the next generation of healthcare delivery, healthcare service systems? Please, let's give a doctor that said, I have no time to stay as a doctor. I have to change my work situation, and also all the support systems so I can do even a better job. Dr. John Moore, where are you? Let's give John Moore a big applause, and thank you very much. See you next year in Paris. John, welcome.
Hi, well, thank you very much for this opportunity to be here. This is quite fun because a lot of my job has already been done for me, because watching the previous panels and interacting with people in their poster presentations, everybody already gets what I'm going to tell you. But hopefully what I'll do is try and push everyone just a bit further. So my name's John Moore. I am coming from the New Media Medicine group at the MIT Media Lab. Our focus at the Media Lab is really about what we call inventing a better future through technology. And our focus on technology is about humans and machines and how they work together better as a team. To tell you a little bit of background before I get into showing you a vision kind of what I think is the future of healthcare, I want to tell you a little bit about my story about how I got here. About 6 years ago, I graduated from medical school. And I was very excited. I was very optimistic that I was going to provide the best care I possibly could, and that I was going to be a great doctor. And I figured I learned all about patient-centered care in medical school. This was starting to be part of what we're educated about. And it was obvious. I would just put my patients first and done. And then I got out in the real world and I saw, well, it's not so easy. As we heard in one of the last sessions, there are a lot of barriers there, and in fact, the patient-centered aspects are just little islands, little fragments out there. After all, making a patient come to your office, sit in a waiting room, and then have 15 minutes to interact with you is not quite patient-centric. It's a little more centered around the doctor. And so I tried anyway. I tried to really educate my patients. I sat down in that 15 minutes that I had, how I was constrained, and I educated and educated and educated, and patients came back and they hadn't changed their diabetes management, no changes in diet and exercise, no changes in their medication adherence. Or I would diagnose a patient with glaucoma. I had started in ophthalmology training, and I said, yes, save them from blindness. And they'd come back and they said, Doc, there's drops, terrible. My eyes feel fine, not going to do it. And I said, no, I mean, we spent hours on this. 15 minutes. But it wasn't getting through, and my take on it was not that these people were not capable of understanding this. It wasn't health literacy. It wasn't health numeracy. Nobody learns in 15 minutes. Nobody learns in a stressed environment where they have lots of concerns on their mind and don't know what's coming up next and don't know when the doctor's going to take their hand off the doorknob. We needed something different. So I said I'm going to quit, and decided to go back to school, and particularly decided on the Media Lab because it's a place where you are kind of free to roam and put aside all myths about what is possible. They really encourage us to try different things. So enough. Let me show you what I'm talking about. So I'm going to walk you through a video here. I want to challenge you that, I presented this the other day at a session, and I told them, well, this is a decade. Some of it is 2 decades off. That's because of the culture and the philosophy that need to change. In terms of the technology, we can do this today. And with a motivated group of people like you who are embedded in this field and understand this, if we get a vital capacity, if we get a force of people who are ready to make change, this type of change can happen today. The technology is not the limiter. It's our imaginations and really the culture that we need to shift. So the first image I'm going to show you here is one that I'm a little bit conflicted about because it's in the office. And really a lot of what you'll see is that everything that I do is mostly outside of the office. But it begins here. If we want to make decisions with people, we need to engage them in a way that incorporates their opinions. So the first really drastic step that we need to take is the doctor is not controlling their computer, it's the patient. So what we're used to seeing is people sitting with paper charts and looking over those paper charts at the patient, and that's what we heard before, and now we're doing it with computers. And maybe we're even doing it with iPads, but the iPad in that paradigm still promotes the same paternalistic model of care. What we need is to open up everything else. And we need to take it to the extent that the patient owns all of this data and controls it, so it's not us giving them access to their data, but them giving us access to their data. Even taking it to that extent that the patient can cut off the doctor, that they can control who has access and when, and to their family members and their friends. And what it means in the end is that they can be involved in these decisions. And what it also means is that we can build interfaces that look exactly the same in the patient's home as they do in the office. So in the paradigm of care that we build, when the patient shows up in the office, they don't wait in a waiting room. They go right into a room, and they have access to their data immediately, because that's what they're used to. When they're at home, they have the same interfaces. And when the doctor walks in, nurse walks in, other health practitioner walks in, the patient says, hey, this is what I need to address. And we've taken that time to engage them as a participant. And we help them make those decisions, and we better well do that because when they go out into the world, they're the people who have to manage these decisions. So what we do is we use our system to automatically synchronize with the devices in patients' lives. So this is a device called a Chumby. It's similar to a tablet computer, except it kind of feels a little more friendly. It sits on your kitchen counter and it's always on. So we do these types of interfaces on cell phones, tablets. We've done it directly on televisions, on Chumbys. We'll do it on your bathroom mirror. We'll do it on your refrigerator, wherever that information is pertinent to you. Because our goal is not to alarm at you and tell you what to do and train you. Our goal is to give you an awareness so that you can be motivated and self-reflective. So the patient here uses this to track their medications, monitor blood glucose, all of those types of metrics, take their blood pressure, and get feedback that helps them to manage this care, and it's all synchronized back with the office. Now, they also have tools to manage their diet, so it's just not about illness, but it's also about wellness. Using microphone input, picture input, we can track diet. We can track people's exercise. This is nothing really dramatic that we can use accelerometers, but we can make persuasive interfaces that help them understand. This is a patient with Parkinson's disease. We can put accelerometers on them that track their tremor over time and can correlate that with their medication adherence. Patients will start playing games. That's obvious to all of you. So this is a game for physical therapy that the patient does a heel slide exercise and it transforms into this shuffleboard type game. So we make it engaging and fun, but what we do beyond that is the physical therapist actually controls the state of this game remotely. So when the patient makes progress, the physical therapist says, hey, we need to up the number of reps. We don't send an email or a text message. It changes the state of the game. And we send messages within that game that encourage them. And they compete in these games against their family members or friends or peers that are dealing with the same issues. So it helps to really motivate them socially as well. And because we do this across lots of patients, we can aggregate those statistics and we can actually change the way care is delivered. We can learn about what types of exercises work most effectively when we aggregate across many people. And again, we give patients the ability to control that. The patients say, hey, I'd like to share my data de-identified with the community of people who are dealing with the same issue so that they can aggregate these statistics. It's no one else that gets to make that decision except for them. This is an interface that we're building with the Microsoft Connect for patients with heart failure. So the issue is patients with heart failure are struggle to really self-manage, and there's been a great deal of research with patients with heart failure who are really on the limits and titrating them, getting them stabilized so they don't have more hospitalizations. But what about actually letting them be self-efficacious? Get feedback about their own performance, self-regulate when their heart rate's too high or when their pulse oxygenation falls, so they can feel that they're exercising within their safety limits, improve their stroke volumes and improve their cardiac output so they can actually improve their own functional abilities. And what we do in addition to tracking them during these games is put sensors on them that they wear throughout life so that we can correlate their game performance with their actual activities in life. So none of this is really a great surprise to you yet. I think health gaming, accelerometers, all of that is really part of the vision that you all see. We're just putting it together in something that aggregates it together. But where things really start to differentiate is when we start thinking about entirely new paradigms of how we deliver healthcare based on this assumption or these assumptions. So here's some researchers, some colleagues of mine, of doing research about human interactions. So they can model people's facial expressions and their gestures. And what we do is we use that to create automated agents who become peripherals to physicians, to nurses, to other healthcare practitioners. They don't replace these professionals. They augment our abilities. So they let the robot be the robot and the human be the human. So they take away all those repetitive tasks that we know we have to ask the same questions over and over and over again. They do that for us with the patient in the comfort of their home, sitting on their couch, relaxing, calling up a family member or friend to get this information, and letting us deal with them on the more important issues. We're also building robots. Some of my colleagues are building robots that understand people's facial expressions. They're able to show emotion back to people so that they can start to be coaches that help people on a daily basis with managing these issues. Again, these are just extra abilities that we provide. In the end, the human is still there. The health practitioner is still there. And video conferencing is a very small part of what we do. In fact, we think that video is actually one of the least important parts. Instead, we're building tools that actually allow people to collaborate remotely. This is a patient with a prosthetic limb, and one of my colleagues has helped to devise an interface that allows the prosthetist and the patient to point to objects virtually over the internet, and the patients have little kits that they can adapt their prosthetics so that they're more comfortable. Same process that they used to do that required the patient to come in, travel, sit in the waiting room. Now we do it remotely. We do it in real time as issues arise. In addition, we're rethinking instruments. So this is our version of a stethoscope. It doesn't have the little earbuds that you put in. It costs about $10, and my colleague has built this so that you just put it on your chest at home. Everyone will own one of these, and it streams it to your own computer so you can hear it out loud, and it streams it to your doctor or your healthcare professional's computer as well. So it allows us to bridge those gaps where we thought before, well, we can't do that remotely. And what this really means in the end is with all of this data, with all of these new ways of engaging people in their care, we can communicate with them in very different ways. So our primary model of care is through asynchronous micro-interactions. So we say that 15 minutes is too short, but that's because it's 15 minutes every 6 months. What if you do 10 seconds twice a week? That dramatically changes the way you provide care. We can speak a lot faster than we can type. We can interpret information a lot quicker than we can put it down into paper format. So here a patient is receiving an asynchronous video message from me. So it's not pre-recorded and delivered. It's personally delivered to that patient, but they watch it when they want. So we don't need to schedule. In this case, I might be telling the patient, good job, keep it up. How dramatically different is the psychology of hearing great job from your doctor than struggling to get an appointment? Or maybe the patient had a side effect and I'm saying, hey, that side effect is really common. try this. And really, this is the socially engaging part of it. But most of the messages we send actually change the state of the programs that they use. So if I want to change the dosage of a medication that they have, it happens right in the interface that they use. It's not some disconnected email or text message. And where we really are thinking about the future of medicine is how to help people understand the complexity of their disease. We really want to elevate their engagement to a level that previously was thought impossible for patients or for people who aren't health professionals. So I did some work with patients with HIV. And particularly, we worked with a population who was considered to have very low health literacy, high school education or less, never used a computer. Some of them had a history of alcohol and drug abuse that was quite significant. And I said, well, everybody's the same. When you build technology to help people with their health, in the end, they're not concerned about what the technology is. They're concerned about feeling in control. They're concerned about getting the help that they need. So what we did was we reduced it down to a very simple thing, and that was a simulation of what's going on in their blood. The problem with chronic disease is that people can't see it, they can't feel it, they can't hear it. We think when someone doesn't take a drug that's supposed to save their life, they must just not get it. They must not be able to comprehend. But I challenge you to think about the situation that you show up in a doctor's office and they say, hey, you have something invisible in your blood. It's called a virus. It's going to kill you in 5 or 10 years. I'm going to give you this drug. It's a cure-all. You'll be fine as long as you take it every day. You may feel lousy, but just keep it up and I'll see you in 6 months. And you're probably going to say the same thing. You're going to say, get lost. And you'll go out and you'll live your life. But what if you could see your actions in real time all of the time in a way that actually helped you feel comfortable? So this is a simulation of HIV. The big gray cells are T cells, part of the immune system. The little red ones are viruses. And there's a barrier around each of these T cells that is protection provided by the medication. And so this is a simulation or almost a game that you play in real time in your life. So over the course of hours, we provide people with actual estimates of how much medication is in their blood at any one time. You see it go up and down. So we're teaching people pharmacokinetics who have never taken algebra, who have never taken calculus. They don't understand exponential equations, but they don't need to. It's personalized and it's dynamic. They watch it change and they understand it. And so this patient here misses a medication. They see the level of the Zygen up at top fall into the intermediate region. Happens in the course of hours, and they start to see themselves getting attacked by this virus. And over time, what you'll see is they miss more medication, the situation looks more dire. And I had patients come to me in the middle of this study and say, Doc, I was getting attacked. I took my medication right away. Well, before we asked them these questions, we said, how important do you think it is that you take your medication? And they said, well, I know it's important. You've told me that. But if I miss it now and then, I don't feel a difference. I don't really know. But now they're seeing it. They're identifying with it. And even more importantly, they see all that virus and they say, hey, I think we've had conversations before about how not to spread this, but I want to ask again, does birth control help? And we say, no, we've told you that before. Abstinence or condoms. But now they're asking. So it's a very different relationship that we produce that really is what we think will drive outcomes in healthcare. It's that relationship. The technology is just the tool to get us there. Because now what we have is a common ground on which we can communicate. So if we want to have a new form of healthcare delivery where we interact very frequently in small bits, right as people need it, we need to be able to orient ourselves very quickly. If I have 1,000 patients, I can't spend 15 minutes going through an electronic record, clicking through tabs, and trying to figure out what issue I need to discuss with this patient. I need to look at a picture, and I need to know how well are they controlling that disease, what's their level of knowledge about it, and what's their level of motivation. And then I can deliver healthcare in the way that I need to, in a way that they can understand, and a way that they can act upon. And now where we're headed from this, so this is one tiny little visualization. So let me break this down a little bit. So this is the patient's view of their health record that we're headed towards. And what it's going to look like is a model of themselves. So you may see things online now that have a body that you can explore. And you can zoom in and look at anatomy, or you can find information by looking at the heart. And that's a great step in the right direction. But where we're headed is when you look at this body, you see yourself. You see all of your data from that accelerometer, from the cardiac rehab game, from the orthopedic rehab game, from your diabetes management, your hypertension management, all projected onto that. There's nothing that's out of context for you. We need to embrace the motivation that people have to be active participants in their care. They're relying on online sources of information now because that's what they can get their hands on. But they're swimming in a sea of information that they're not sure how to put into use. It's scary to them. It's overwhelming. So what we need to do is embrace that. We need to give them the information that they want, but also the information that's appropriate for them. So where we're headed is you can zoom in and zoom out of this body. So I'm showing you a particular view that's focused on hypertension. This patient here shows a graph of their medication adherence over time for this drug called hydrochlorothiazide. They see that they miss the drug here and the level fall off. They also see their blood pressure aligned with that medication adherence, so they can see the correlation that their blood pressure went up here when they weren't taking their medication. But they can also see a zoomed-in view of the body that's zoomed in on the distal convoluted tubule of the kidney here. Most of my colleagues that I graduated from medical school, including myself before I built this, probably couldn't tell you where hydrochlorothiazide worked. But this tool puts that in the hands of the patient so that they understand. And what it becomes is a tool for medical students, for physicians to get continuing education, but all of us as a team working towards the same goal. And what you'll see is that this simulation here actually shows the hydrochlorothiazide molecules blocking channels here. And all this salt, we talk to people about salt all the time, they have no idea why. All this salt goes out in the urine, and when they don't take their medication, all this salt starts to flow from the urine side into the blood side, and it increases the blood volume, and it increases their blood pressure. And we can scrub back to the time when they were doing well taking their medication and see this medication flow into place. So not only do we have those tools on the patient's devices that give them the here and now, but we're building the ability for them to look in the past, the present, and the next thing is the future. So we can forecast based on your behavior and based on results from others where you will end up if you continue your current habits, so that we can help people project into the future, because people respond to all types of different things. Some of them will respond to this information, these biomedical models of disease. Some will respond to where things are in the future. Some will respond to what they've seen in the past. Some won't care about this stuff at all. They'll just care about that person on the other end who is overseeing them and coaching them through their problems and giving them the thumbs up when they do a good job or not. Everyone is going to be different, so our goal is not to choose for them, but to give them these suite of tools in which they can choose for themselves. So that's my story. And the work that we're doing is all open source. Our goal is that this platform will be something that anyone who's interested in innovation in healthcare can download and can build new plugins onto. It will be free. The goal is initially it will be a platform for research, but within 3 years' time I plan to start a medical practice that works in this matter and hopefully try to help spread this technology to others who might want to use it and give them some advice about what works and what doesn't. And we'll be publishing research in the now and in the coming years about the effectiveness of this approach to care. But in the end, the thing I want to drive home is that it seems very high-tech, but when it comes down to it, simplicity is the key of it. It's not a fancy graphs. It's seeing in my blood what's going on to the best of my knowledge. It's seeing what effects I can anticipate in a very visual, very interactive model. And in the end, it's about the relationships that form around this and the new types of communication that we can enable when we have technology to give us this common ground. So, thank you.
Why don't we take a minute and chat with our neighbor? And now when we have John here, we end his lecture with some questions. So ask your neighbor for 30 seconds to a minute, what do you like to ask John? I get the microphone.
Okay.
A handheld microphone. Okay.
Please don't be kind. Ask hard questions.
Okay, let's see if we have someone who would like to ask John, is this real? Is this just fantasy? Come here in the front. Here comes John. The first question.
Here it comes.
Say who you are.
I'm Connie Hahn from Jacksonville, Florida in the U.S. And I was wondering what you see are the most applicable components or the best use of this for patients, regardless of what country they're in, where there are very limited resources. This, you're right, it sounds very high-tech, but in the simplicity, how do you envision it could help those in areas of very scarce resources?
Sure. So the issue here is a lot of this technology doesn't require literacy or a specific language. A lot of it is visual. The places that we're most interested in translating it to the developing world initially is to HIV, tuberculosis, problems like that, where the fundamental problem, lots of people will tell you that it's access to medicine. We don't believe that's the case, right? Once you give access to medicine, if you have a model of disease or an understanding that directly conflicts with the need to take a medication, then you're not going to get anywhere. So we're most interested in looking at chronic diseases like HIV and TB and others to really motivate people to take those medications, but based on their own cultural terms and their own models that reinforce that. But also teaching them towards the biomedical models, that if we can let them see it, interact with it, then we can make it accessible to those. Now, there are issues right now. We do a lot of this on smartphones. So the question is cost. I firmly believe that in 5 years' time, that's not going to be an issue at all. So by the time people put resources in the right place, are ready to deploy the technology, that nobody's going to be making phones that aren't smartphones anymore. People will be making phones that have projectors in them, and they have near-field communications and gyroscopes. And those things will be expensive. But a simple smartphone that can deliver the visual information that we're giving, it'll be ubiquitous. So that won't really be the cost issue. And this technology scales at a phenomenal rate that you can give it to lots of people and have a few coaches provide care to people anywhere in the world without much cost.
My name is Henk van Stel from the Netherlands. Do you think that people will comply with all those data collection on just about anything that they do during a day? I have a bit of a big brother is watching you vision when seeing this.
So it's a very good question. It's kind of the first thing that I focused on in my HIV work, which is the first study that I actually did. And the issue was we really considered pill caps to automatically record this early. One of the problems was we didn't have the funding for it at that time. And another of the problems was that fundamentally, I believe that people will report and people will use tools that give them value, right? So the problem with starting off with using tools like that remove some of the burden of reporting is that they also remove some of the connectedness with the value that exists. So what I tried to do was align the incentives of the patient with the feedback that they were giving and the effort that they were putting in. So what I found from these patients was that they had to report their medication adherence every day, multiple times a day, and they did it with me for about a year, and they didn't care. Because in the end, they saw this picture and they said, I can take that thing and hang it on the wall, and I know it's not going to change, and I feel like I have control over this disease that previously was just a big question mark to me. So that's the trick. This is an extreme example. Will it work in diabetes? Will it work in hypertension? Will it alleviate that? And will the value that you give outweigh the burden of reporting? And in some cases, it won't. So we'll need to try other avenues. We're building tools that will automate these processes. So we're building our own systems for automating medication adherence reporting with a pill box. Or we're using other people's tools with glow caps and other things like that to automate those processes. But in the end, you need to really connect them with the incentives. And our incentives aren't monetary, they're social and they're personal. But everyone will experiment with different types of incentives. And that, in the end, is the proposition. So you start to do this across lots of different problems, and suddenly you could overwhelm people. But if there's balance in each one, and you leave it up to them to choose. And I think that's how we achieve it.
Do we have one more question? So, let's give John a big applause. Thank you very much for coming. See you in Paris next year. Thank you very much.